Welcome. We appreciate your time today. My name is Dr. Nicole Diaz, and I am happy to present to you on behalf of my colleagues at Unity Health a very interesting case of infective endocarditis. The title of our presentation today is From Port Flush to Pathogen Hunt, a challenging diagnosis of endocarditis with Providencia rettgeri. As we all know, infective endocarditis is a very life-threatening disease characterized by the damage from inflammation and infection to the heart valves. This ultimately causes disruption to cardiac output and can lead to dangerous complications. Infective endocarditis has high morbidity and high mortality, and it is a serious disease that should be treated urgently, if not emergently. Smaller hospitals may not be appropriately equipped to provide the adequate intervention needed, and therefore timely investigation and identification is of key importance in order to be able to transfer the patient to an appropriate facility in a timely manner. We would like to present an interesting case of a 51-year-old female with a known history of chronic pyoderma gangrenosum and melanoma in remission. She is being chronically surveyed for remission with repeat PET scans annually. For this, the patient had a port in place for her chemotherapy regimen. On presentation for this visit, the patient appeared ill and was hypertensive, tachycardic, and febrile. Labs were suggestive of a urinary tract infection and sepsis, and showed elevated lactic acid and worsening anemia. She was started on broad-spectrum antibiotics and received 2 units of blood with mild improvement. Initial blood cultures were confusing because they showed atypical organisms including Providencia, Enterobacter, Rhaltella, and MRSA. These organisms are not typically found in blood cultures, much less causing systemic symptoms. The patient at this time was treated for severe sepsis with appropriate fluids and broad-spectrum antibiotics. The final cultures were received, and the main organism growing was Providencia rettgeri. Due to physical exam findings showing new onset heart murmurs and poor perfusion, and along with her history of installed hardware, which was her port, we became concerned for infective endocarditis. An echo was ordered and ultimately showed bivalvular vegetations on the aortic and mitral valves. Cardiothoracic surgery was consulted and the patient was transferred to St. Vincent Hospital for surgical repair. Infective endocarditis is a very dangerous and complicated disease that requires a lot of urgent intervention to manage. Typically, patients who have this disease either have mechanical valves or a history of IV drug abuse. It is very rare to see bivalvular endocarditis on native valves. It is rarer still to see an infection from Providencia. As I hope we emphasized, this is likely due to the infection around the port that was flushed. Even still, the patient likely had existing valvular disease and damage that led to this opportunistic infection to take over and become a vegetation. We think it is important to emphasize keeping an open mind when suspecting endocarditis in a patient that any possible organism or modality is possible. It is easy to consider a growth on culture like this one to be a possible contaminant. You need precise microbiology review, prompt treatment with systemic IV antibiotics, and even surgical intervention to address valvular damage and prevent systemic complications such as heart failure. Thank you for your time today, and please review our references for further education on the subjects discussed.